study. And thank you, Chairperson Dr. Deepak and the organizers for the opportunity to speak in this meeting. I'm going to tell you a story from the Pune Maternal Nutrition Study, which many of you would know I set up 30 years ago. And now the participants in the birth cohort have grown up, and many of them have now developed pre-diabetes. So we are able to trace the life course history. My department has a logo of mother and baby because that's what our focus of research is. And the modern Ganesh was changed from his original habits to clicking the mice rather than traveling on the back of this mouse. And that has been the rapid transition in the India over last 50 years or so. And this is my institute, the KEM Hospital and Research Center. So the natural history of diabetes, as we depict it, it starts with a normal glucose tolerance state, then progresses to pre-diabetes, and then finally it crosses into the cut points, which we define as diabetes. Pre-diabetes has attracted attention mainly because the participants in the diabetes prevention trials are chosen to have pre-diabetes so that we can interact with them, we can intervene and try and prevent diabetes. But I'm going to tell you the story that starts much before that time, even before probably NGT, if that's possible, and then take you through the life course of a participant in the Pune studies. The typical dogma in a textbook for type 2 diabetes is that there is a genetic inheritance, which we say is non-modifiable, especially because it's polygenic for type 2 diabetes. Because we say the susceptibility is non-modifiable, we have concentrated on the precipitating factors, and which largely include aging and obesity, contributed by changes in diet, physical inactivity, and stress. And therefore, the participants in the diabetes prevention trials are usually in 50s with a body mass index in obese range and with an impairment of the glucose tolerance. And I'll try and convince you that this is too late and we are going to do too little for them to benefit from that. The challenge to this dogma came from David Barker in 1990s when he wrote his Thrifty phenotype hypothesis. I have to tell you that I suggested him the name Thrifty phenotype when he first met me in 1991 in my office, trying to convince me to join him in his research. And what he showed me was this remarkable paper in British Medical Journal, where he showed that lower birth weight was associated with higher incidence of glucose intolerance and metabolic syndrome in a cohort which he had studied in the UK. Because India is world's capital for low birth weight babies, he was traveling in India to see if a diabetologist would be able to join him in this research. And after this paper, he wrote this hypothesis where he said type 2 diabetes is the outcome of the fetus and the early infant having to be nutritionally thrifty. And I have joined him since then and done a lot of research with him. Later on, from FOAD, which is what David Barker said, fetal origins of adult disease, the idea changed to developmental origins of health and disease, to incorporate the idea that it's an ongoing process starting around the time of conception, depending on maternal factors and the intrauterine environment, heavily driven by epigenetic events rather than the genetic sort of inheritance, reflecting in fetal growth and development, manifest in the birth phenotype, and then continuing to go through the childhood, puberty, and adult age, ending up with risk factors, morbidity, or mortality. So DOHAD has brought us out of the genetics plus the adult lifestyle conundrum. And Pune Maternal Nutrition Study was set up in 1993 in 6 villages near Pune exactly to answer these questions. The two primary aims were to find out the determinants of fetal growth in Indian villages and to study the life course evolution of phenotypes, especially what we call diabesity, that was combination of diabetes and adiposity. We studied over 2,500 women who were married but not pregnant. 814 of them became pregnant, who were intensively studied 3 times in pregnancy. They delivered babies whom we measured again quite elaborately at birth, and then measured them every 6 months for 18 years, and then subsequently every year for their growth. Every 6 years, we analyze or call them to the department for an overnight stay and study their size, body composition, nutritional intake, physical activity, glucose tolerance test, cardiovascular risk factors, body composition, cognition, a lot of things. The last follow-up started in 2019 at 24 years of age, but in February 20, we had to stop after we had studied 270 families out of possible 700 because of the COVID pandemic. We will pick up when the time allows us. And we have created an extensive biobank over the last 30 years with more than 300,000 tubes in our freezers from various biological fluids. At 18 years of age, that's what we are going to concentrate today. These children had a very substantial prevalence of prediabetes. Almost 1 out of 3 were pre-diabetic, boys more than the girls. 27% of boys had impaired fasting glucose. 10% of boys had impaired glucose tolerance test, while in girls, about 10% had IFG and IGT, and 2 had become diabetic, but 1 of them was MODY. Just to show you that there were considerable nutritional deficiencies in this population shown here for B12. We are not going to talk about that today, but almost 50 to 60% of the population was B12 deficient. In short, about 40% of males and 20% of females had some glucose level which could classify them into ADA criteria of prediabetes. And how did they differ from those who were normal glucose tolerant? To begin with, men were shorter by almost 2 centimeters. Females had almost a similar height. Body mass index on higher side, but not significantly. Remember, the mean body mass index only 19. And almost 45% of this population was still underweight. That means body mass index of less than 18.5. 8.6% of high glucose, that's pre-diabetic, had overweight obesity, 5% in the normal group. This is by the international criteria of BMI 25 and above. When we measured body fat by DEXA, males with impaired glucose tolerance had higher body fat, so they were adipose, but not girls, though girls have much more body fat than boys as a physiological phenomenon. And triglycerides were borderline high in the high glucose children. Then we decided to look at the 2 physiological measurements of insulin sensitivity and insulin secretion, which we know contributes to the glucose intolerance. And I look upon this as a capacity load imbalance. Load comes from insulin resistance, and capacity of the beta cells to respond to that determine your glucose tolerance. And we had the opportunity to study their childhood measurements. And this is because of the birth cohort prospective measurements. A Danish philosopher had said this long time ago, he said life can only be understood backwards. And this is how it looked. Those who were pre-diabetic at 18 years of age naturally had higher glucose because that's how we have classified them. Green ones are the normal glucose tolerant. But what is surprising is that those who are glucose intolerant at 18 years had higher glucose at 12 years and higher glucose at 6 years of age compared to those who remained normal glucose tolerant at 18 years of age. So what you see at 18 years is just a reflection of the impaired glucose metabolism, which is detectable as early as 6 years. That was the first time we obtained the blood in this cohort. For insulin concentrations in the fasting state, the insulin concentrations in glucose intolerant people at the time of 18-year glucose tolerance test were higher, as has been shown in many other cohorts, but we will discuss this, what it means. However, their insulin concentrations in fasting state at 12 and 6 years were no different than the normal glucose tolerant people. So obviously, glucose and insulin cannot be interpreted alone because both are very interdependent. And that's why we decided to use HOMA model. I trained in Oxford with this group 40 years ago, and we are very fond of using this model. The model is developed in about 25 young, healthy Englishmen. Therefore, their values are taken as normal or 100%. And what figures we will show for our cohort or any papers which show you are a relative comparison with these young, healthy Englishmen. And nowadays, it's very easy to go to the site of the DTU, the Diabetes Trials Unit in the UK, use the HOMA calculator and calculate the values. So this is what we did. We calculated HOMA S, that is HOMA sensitivity. This is the inverse of HOMA resistance, and HOMA beta, which is the beta cell function. And what we see is that those who were impaired glucose tolerant or pre-diabetic at 18 years had a lower insulin sensitivity at 18 years, especially, at 18, not at 12 years and not at 6 years. So they showed impaired sensitivity at the time of diagnosis of pre-diabetes. On the other hand, the beta cell function was comparable even at 18 years and of course at 12 and 6 years. This could be slightly confusing. There is a progressive change from early age to 18 years, but no distinction between the two groups. And this change from early to late years is very interesting. You can see at 6 years, the Indian children had almost 300% sensitivity. That means they are 3 times more sensitive than the young 25-year-old Englishman. By 12 years, they had come down to about 170%. And by 18 years, they were about 80% of the sensitivity of the Englishman. So they were more resistant than the similar aged Englishman. While the beta cell function at 6 years was about 60% of the average English, it increased to 80% and over 100% by 18 years, probably to compensate for this decreasing insulin sensitivity. So it's an important lesson that HOMA S and HOMA beta change progressively and concomitantly during the life course. And therefore, we have to put these into relation to each other. And this was actually sort of popularized by Bergman in about late 90s and early 2000 by what he called the hyperbolic correction, where you plot insulin sensitivity against insulin secretion and see that there is a hyperbolic curve. And this actually led to description of what we call disposition index, which is a multiplication of sensitivity and secretion. And this remains constant over a period of time, as we will see. So this is the plot of the HOMA sensitivity against HOMA beta in this population at 6 years, 12 years, and 18 years. And what it shows is that at 6 years, as I told you, the children are much more sensitive and with a relatively lower beta cell function, because that is what is required to keep the glucose in the normal range. By 12 years, their sensitivity is shifting to the left and beta cells are compensating by increasing their function. But by 18 years, the sensitivity has contracted considerably and the beta cell function had to increase proportionately. And the green group is the normal glucose tolerant. Red is the pre-diabetes, and you can see a clear separation. The beta cells in those who are pre-diabetic are not able to compensate for the increased insulin resistance. And this is again shown as a log-log plot that from 6 to 12 years, there is a progressive change in insulin sensitivity, that is fall, rise in beta, but at each point, if you look at the median value, those who were diagnosed glucose intolerant or pre-diabetic at 18 years are tracking on a lower line. That means the abnormal response of the beta cell to the prevailing insulin was as early as 6. At 18 years, again, as I told you, we could find, yes, difference in HOMA sensitivity, not by the HOMA beta measurement, but disposition index was already low, and that was what was contributing. So failure of beta cell compensation to the changing insulin resistance or the sensitivity is the major contribution to the developing glucose intolerance. Because we have so much other data, we are able to talk about other things. Were these children born low birth weight? No, but they were born shorter at birth. So both the females and males had lower length at birth. The girls remained lower height throughout their 18 years. Boys also a little bit on the lower side of the reference range. Weight-wise, girls have remained low weight and boys near normal weight, but progressively produce or increase weight during puberty so that their BMI is higher than the normal glucose tolerance during the pubertal years. So this is a demonstration that if you are pre-diabetic at 18 years, you were born lower length or you were born shorter or stunted, and that was the manifestation of intrauterine growth restriction, which David Barker had described. What about the glucose at 6 and 12 years? I told you that they had high glucose. This we have modeled, and what we show here is that glucose level at 6 years was strongly related to glucose at 18 years. And if you look at the lowest and the highest quintile, that is the fifths of glucose distribution, at 6 years, the highest quintile glucose at 6 years increased the risk of pre-diabetes by 3 times at 18 years. And for 12 years, if glucose was high, it increased the risk 6 times. And the ROC shows that the area under the curve was about 0.7. So then we looked at other factors which might be related to pre-diabetes at 18 years. And what we find is female sex has a lower risk, which I had shown you before, 20% against 40%. Mother, ever overweight. Today we are able to, or today we think that overweight obesity in the mother is driving the epidemic. But in this village population, lack of obesity in the mother was a driving factor for glucose intolerance in the child. Mother's glucose, though they were normal glucose tolerant in pregnancy, within that normal value, higher glucose predicted higher glucose in the baby. So evidence for intrauterine programming by maternal glycemia. Paternal glucose intolerance increase risk only in the female child. And as I said, lower birth length and lower head circumference were higher glucose. In addition, we have shown new 6 and 12-year glucose and higher body fat in males. So this is a complete life course demonstration that what factors program the risk of high glucose in the child right from before the time of conception, during pregnancy, and through the childhood and puberty. So what we are now saying is, unlike the conventional model, we are saying that diabetes prevention trials should start very early in life, especially by reducing the risk factors in the young girls so that they produce children which are less likely to be diabetic in future. And therefore, this has become a famous saying now, it all begins before the beginning. So to summarize, the implications of our study are that type 2 diabetes has an intergenerational life course evolution. Metabolic abnormalities are evident very early in childhood. There is a progressive accumulation of risk. There is an imbalance in insulin sensitivity and secretion progression during childhood and puberty. We are able to predict future risk through parental glucose tolerance, birth length and head circumference, and fasting plasma glucose in the child. This has implications for public health policy to look into improving the fetal growth, which of course for more than one reasons is true. Childhood screening for glucose so that you can do high risk targeted intervention, and lifestyle advice for the whole population. Now, it would be interesting to see whether these young people in future develop diabetes at young age and whether our findings would contribute to treatment strategies in them. Though we will have to wait few years in the cohort to achieve that, we have done the clusters analysis in 3 places in India. This paper is now accepted for publication in Diabetologia, and I'm going to speak about this day after tomorrow afternoon to talk about subgroups or clusters in Indian clinics. 3 clinics contributed data to this. My own clinic with nearly 2,000 patients. Dr. Banshi Sabu from Ahmedabad contributed about 250 patients who were diagnosed before 45 years of age. And Dr. Anupam Datta and Sanjeev Kakati from Dibrugarh. And interestingly, what we find is severely insulin deficient diabetes is the predominant group in our young type 2 diabetes patients in the clinic, like what we showed cohort Pune Maternal study. It was the failure of beta cell to compensate. Ultimately, a time comes when load becomes too much and they crash. This was true in Ahmedabad, and this was very much true in Assam, where almost 2 out of 3 patients in the Assam Medical College Clinic were severely insulin deficient. So if you are interested in this, please come and join me in a couple of days' time to listen more about these clusters. Finally, thank you to the participants, my department, and a series of collaborators from India and abroad who have contributed to this work. Thank you, Chairman. Thank you very much.